Hi, my name's Professor Faye Roddick, and I'm the chair and founder of CARM. So it's really good to be here and to hear your presentations and all the work that you've been doing. So well done for all of that. There's just just a question that I have and a comment as well. So as Scholar said, CVD underpins what CARM is all about. It established the organisation. And one of the things that we were doing very early on is, as Scholar said, all the screening in churches and different places. And we were picking up an awful lot of hypertension, diabetes, blah, blah, blah. This point of care testing is something that we've been saying, well, look, we need to do something more than just giving people a little bit of paper to take to their GP when they've got this really high rate of hypertension. They go in a queue, and then, I mean, some of them don't go because there's a challenge of follow through. So what I just wanted to ask was, it's brilliant picking people up in the community, but what is the loop? What is the feedback loop? What actually happens? So that person gets the test, they find out that they're high glucose, hypertension, blah, 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 and what happens when they don't go? Or even if they do go, because what we do know is that there's issues around compliance, there's issues around trust, there's issues, all the things that people have picked up. So my question is, what do we do? What is the plan to be able to make sure that we're continuously preventing CVD in the Black communities and other communities? And also the funding. We've had these arguments all the time. This funding is too short-lived. We see the benefits, you've all shared about the benefits, and then it stops. What do people do then? So those are just two of my points. There's many more, but I'll leave somebody else to answer. And then
okay, absolutely brilliant question, and we've got part of an answer, I think. So I'd like to bring Nana in first, maybe to say what we did in this project, but what we're lucky enough to be doing in the next project, which kind of partly answers your question. It doesn't fully answer it, but I'll come back on that. Okay.
Brilliant. So again, thanks, sorry. So with the project...
Might have to speak up a bit, I think.
So with the project, we work with our software partner, Health Diagnostics, and so the referrals were trickling into GPs so they could see and pick it up in their pathology inbox. And again, we know primary care have, competing priorities and, all of that. So behind the scenes, we were having conversations with them around helping to fund sort of capacity to handle some of these numbers that were coming in. And so that helped to sort of manage some of these numbers. But again, it doesn't really solve the problem, which then brings me to what I was saying. The idea was to scale. So what we have now is, if you want a minimum viable product that we can scale. So what we're planning to do is, with the bid that we've got from Shaft Foundation. So what we want to do is to scale to that next step, which you mentioned. After finding the people or reaching them, how do we then support them to manage their condition if primary care is struggling to do that well? So we're going to have some of these things embedded in the next project, hopefully. So that is sort of some of the things that we're doing. And you're constantly going to have that tension. But again, we're hoping to get funding from different sources, really. And just again, I'll give it to that about the funding bit. But again, we're constantly trying to identify, with the partnership, amazing partnership that we have with Health Innovation. It's been super helpful being able to identify different parts of funding to be able to keep the work going. Because again, sustainability is an issue. So hopefully we'll get there.
Yeah, great. Before I come back on that, any other thoughts from the panel? Anybody else? You're going to introduce yourself, Nina.
Yeah. Hi, everyone. I'm Nina from Novartis, so I work very closely with Health Innovation Manchester. And from an industry perspective, we're committed to working with the NHS to essentially work with policymakers and health systems, really to look at building solutions that do everything that we've talked about today. And it's really interesting you raised that question, because while I was sitting here watching that, there's some absolutely fabulous work that has been delivered in Greater Manchester. And some of the things that we see nationally is, to your point, how do you make sure that the loop is closed? That if you are essentially detecting, diagnosing, and could you do the intervention in that moment as well? And that's some of the stuff that we're working on nationally at the moment. So we're in a position sort of, we're collecting that sort of data, we're collecting that information to be able to share back to health systems nationally. And I think you mentioned, Anna, there's a piece there about how do you then take that information and work up business cases for ongoing commissioning that encompasses the whole picture. So that would kind of be my sense that certainly that's what we're seeing nationally. That's that piece that you mentioned, that not to miss the opportunity of the intervention in the moment. So.
Yeah.
It's just a comment. And the observation we did during the testing, some people we identified with high cholesterol and we referred them. Let's remember that these people came to us because they trusted us. They felt safe and we gave them the results on the spot. However, some people got back to the GPs and they were told, no, we have to test you again. So it kind of like reversed the clock, because in the first place, they didn't trust the place. And secondly, we all know sometimes results come when you don't know anymore, because they're looking at the post, they're looking at the text. And then, so I'm supposed to bring this to say, in the new project coming, how do we avoid that? Because Mary's come to us and she's confident, she's relieved we found the problem. And our GP says we'll have to make an appointment for you to go testing. You know, what if she falls and brain fix? I'm not going there.
Yeah. So that's a much broader conversation, isn't it? And that relates to what we were talking about with point of care testing this morning. Can you trust and believe that the test that you've done on the ambulance or the test that you've done in community, and is that test lab standard? We did use lab standard equipment. So there's a conversation with primary care and GPs to say, actually, this is the same result if you just send it to the lab. So there's a different conversation if you're doing a different test, which is maybe a screening test, not a definitive one, because it's better to have that screening test which is maybe really quick to do or really cheap to do, rather than really expensive, because there were limitations to what we did. I think Nick, you alluded to it. You need a fringe, etc., etc. It's like a big shoebox piece of equipment. You need to keep the cartridges at the right temperature, etc., etc. It takes a little bit of time to do that. So you've got somebody turning around, not too long. So within that kind of 30-minute window, you have a really good conversation about what the result means and educate somebody, and then hopefully handhold them. I think what I was going to say about the funding bit was for the next project is we've thought really, really hard about the next step, the next evolution of this, and thinking about, okay, well, each contact and each point of care testing with individuals cost X amount. And actually, we've had the money to do that as a proof of value. But making this commissionable in the future, we've got to really think much, much harder about that. And we've had brilliant community partners who have recognized that and kind of squeezed their costs in a way, so that we end up potentially in a scenario where if we're sure that this really does work, and there are community champions hand-holding and then checking up if somebody's been to the GP, if somebody's initiated their intervention, taking their medication and keep on doing it, it's a really worthwhile commissioning thing to do. There's a hand up at the top there.
What a brilliant conversation. I think there's two things that are coming to mind, and I'd really like to hear from the panel in particular. The first one is how do we learn the lessons from this particular example using lab tests? And to your point, sorry, I don't know your name, but to your point, if we're using lab tests, then the communication back to general practice and primary care has to be, we are in this to trust this. Don't repeat it, because that's a waste of time, resource and money. And it's a loss of trust because you were set up as someone they can trust, and then that undermines the trust when they go back and it gets repeated. So that's how do we learn lessons to optimise what we're doing? And then the points, Nina, that I think you were making were absolutely exceptional. We all know that if you have a lack of trust with a system, then every single time you put a barrier, like you've got to come back or you've got to take that piece of paper to your doctor, the chances become a diminished sort of scale, doesn't it? Each time you put a barrier in, the likelihood is you're going to lose that patient to follow up. So all that glorious work, while it might have some resonance and some benefit, will be diminished by asking them to do something else. So that intervention at point of knowledge is absolutely critical. So just really keen to know how we're going to do that sort of lessons learned and sort of loads.
Scott, do you want to come in on that first? Sam lays it down with the microphone. So, you.
Thank you, that's a brilliant question. I think when we started this project, we were given training by the Northern Primary Care Trust. So I think if we have been trained and we're using the equipment that has been deemed fit, and then the results are questioned, are they questioning the system? But I suppose we had in Canberra a webinar where we had these doctors and, meetings of CBD, and somebody was like, as a doctor that's registered for my registration, I like to trust my own results. I think we need to come to a point where because we're co-producing and we're benchmarking, if we have a test as training that is approved, this should really speed up. But we also found out that even though the systems we're using with that software, we're referring people, when we changed, because after 2 weeks, we followed up and people hadn't been seen still. So there's got to be a robust system that while we're using the systems because they're paid for, we're getting the results we need. And in terms of training, obviously there's governance. How are we following up to make sure that everybody's doing what they're expecting to do?
Yeah, brilliant. Donna, George, come in.
We've spent some time actually sorting out our partnership. The one thing that's missing is the partnership with primary care networks, GPs, obviously. We have made some tiny steps of progress, I think, where we've actually worked in collaboration with some GPs. But I think that's what we need to do, when we get to the next stage. Because otherwise, all this work just won't be as effective as it should be.
So, brilliant comments. Any thoughts about how we do that? And then there's a question from Daniel.
Sorry.
And then Nancy.
No.
Okay.
Daniel.
Just a question about the intervention per se. So some evidence around health checks and the very, the fact that the patients or the citizens really doing a health check, the results come high. What people at that point of time say they're going to do is not really what they end up doing. So there's some evidence saying 100 days later they get a phone call and things like, oh, I'm going to go and see my GP. They really around about 10% of people actually end up going to the GP. But what they don't say they're going to do is to talk to friends and family and share their experience. And from the NHS point of view, collecting that sort of information is probably very, very hard to know. Have people actually made lifetime changes? Have they shared with the community their experience? Has that led on to something else? So I'm thinking from your perspective that you're closer to communities, you see that, people more frequently really in different settings. Do you have any anecdotal evidence or any stories you can share about what people have done actually to build on the test?
I'm going to pass on to my colleagues, but I want to put more context to their answer, which is
we often assume that people even understand the information they've been given. So you can say you've got high blood pressure, but if you don't understand what that consequence is, you can't then make changes because you don't understand what they are. And we've got lots of examples of where people tell us they don't understand, and the conversations my colleagues can describe help us then allow them to make action. But that basic understanding, we cannot assume it, and that's why the length of the appointment is really important, that we're not hurrying through and we're giving people the chance to ask the question they may never have asked. I'll pass over to my colleague.
Thanks. I think just going on that, the most important thing saying is we realize that we need to do a follow-up. Because on that follow-up, that's when we find out. So if at the end of the session, what we did, we used a coaching method of saying, okay, Donna, what do you understand from today? So they tell us back what they've done. And we have resources like, if you've got a high blood pressure, what is high blood pressure? And we went through the booklet to say, this is what high blood pressure looks like. And what can you do, to try and help yourself? And then giving that guidance, breaking it down. And then what can you eat? You had somebody mention, like we've got a template by there of what food looks like. And then we go through that. And you had somebody on the video, we actually gave people recipes of how food could be cooked differently instead of eating fried things on. But ultimately, discussing about what has your GP said since then. That's when we found out quite a lot of feedback. There was a gentleman I remember from one of the groups went in. He took screenshots of the blood pressures, and then the GP, the system said, come back and so on. He said to me, look, since morning I've been waiting and the GP's going to come back to me and so on. So yeah, so it's about how are we going through that. When we followed up, we don't have the power to go to the GP and say, I sent Donna and so on, that loop is missing. So on our part, whatever we've given, whatever the information, because from the GP point of view, we've explained in terms of lifestyle, we've explained the results of what looks safe and what looks unsafe. So we're leaving the channel of the GP to execute the treatment plan.
The only thing I would add is this program isn't just about carrying out the test. We do also carry out education sessions. So when we go into a community centre, for example, we will actually talk through such things as, what is diabetes, what is high cholesterol, what does that actually mean for your health, what changes do you actually need to be made. So there's a two-pronged process. So alongside the testing, you will get some advice, but equally we would encourage those individuals to go to education sessions as well, to get additional information. Is that a question?
Yeah.
Hi, my name is Shanti and I'm BHA, and I've been overseeing some of these health checks. And the answer to your question is that it's not one visit that we have. We're in the community, people access us. So if we're giving information to somebody, they've gone away to split it with the family, they'll come and access us again because we're easy accessible. They will know we're at a certain place, we're back in that community centre. They'll come and access us. If they're not clear with what we've said, we will give that information again to them. And what we found, the feedback has been, is they've made changes in the family, not just with the individual that has high blood pressure or cholesterol. They've actually gone home with information in their language that they understand, and they've had conversations in their language with us, and they've made adaptations, which has then helped. So by the time they've gotten to the GP, they've already got that knowledge what the GP might have said to them, put down on your high fat foods and, do more exercise. They've already put that in place, waiting for that appointment. And I think that's the good part of this program. We're easy, accessible. They can come to us many times as they want. They can ask us many questions as they want. And we always leave them a contact number with all our voluntary organisations. They'll access us. Thank you.
Great. There's a question up there.
Hi, I just want to build on a couple of things that Wynne said. So I think the gold standard for making sure that that loop is closed, is making sure that as many steps of that just happen in that moment as possible, that there are appointments available, that we make sure that someone is seen, and on that side of things. But of course there is the person side of things as well. And in this, I'm going to give an example from our testing about the community setting and that really being important. So we were doing some testing at a community centre, and people had just had their blood pressure taken and they were coming outside and waiting for results. And as people were coming out, there were people who had had the test previously, sort of saying like, "Oh, what was your blood pressure?" And then they'd sort of say, and they were like, "Oh yeah, ours was high as well. This is the Nordic table. Come and sit with us." And I think trying to do something about this in your personal life, it's such a big thing if you're trying to tackle it on your own, and it's easier if you're tackling it with other people and support of community, support of family, support of friends. But there is taboo around some of this, and there is taboo around having high blood pressure or that sort of thing. It's not necessarily comfortable to disclose that in the first place. If someone has felt comfortable to disclose that in a community setting, they've already had some of that peer support and some of those questions around what they might do next. That can be culturally appropriate given the setting. It can be related, there are people there from the same community as well. And that's a real strength of it being in the community settings where people feel comfortable to have those conversations in the first place.
Nina, were you wanting to come in?
No, right.
No. Okay, so I have a question at the back, two questions at the back. So, lady in pink first.
Hi, I'm Jenny from MFT. I was just wondering, obviously, in order for the patients to actually get a change in their care, they have to access their GP. Did you come across many people that weren't registered at a GP? And did you have a plan for if that happened?
Who wants to go for that one? We're keeping you busy, son. We've done those steps.
Thank you for the question. Yeah, so when we went to the SO schools, on average of 20 people we saw in a day, maybe 5 weren't registered with the GP at all. And then what it meant was, in some of them, we had to find somebody, which was quite interesting. One of the gentlemen, I remember, had to open ChatGPT. So when I was talking to them, they were typing to translate into the language. So there was an issue of language. And secondly, not being aware. And there's somebody, I said, how long have we been staying here? I think they've been like over a year and they've never seen a GP. And we saw some people who've lived here longer, maybe hadn't seen a GP for like 3 years. And they didn't think they needed to go to GP. And, the answers were, because I've got to go to work and so on, or, I didn't know that I need to go to a GP, something like that, yeah.
I think some of the people that you saw in that particular group were maybe new arrivals to the country, but there are also individuals, who've been here for quite a long time who haven't actually registered with the GP. There was one example where there was one man saying he would never register with a GP. But when we came across those examples, there is a guide that NHS Manchester has actually produced. We generally would talk through that guide with individuals so that they understand, what the process was, and also give them that guide as well. And if they needed any additional support, then we would actually support them. So, because we obviously want those individuals, to be registered, and to be under the care of a GP.
So, and I forgot to mention, so in the ESOL place centres, we deal with the safeguarding officer. She's the lady that really invites us. So when we find issues like that, particularly people who are flagging with very unsafe blood pressures or diabetes and they're not registered, we highlight to say they need to be supported.
Great. Can we go? Sorry, go on, Nick. So we'll go to the lady up there.
Yeah, I think in particular with our testing, we came across a lot of people who said, yeah, I'm registered with the GP, I think, but I've not been in 20 years, or I've not been in 25 years, or I've not been in 15 years, or, oh yeah, I got a letter through, but yeah, I haven't really done anything about it. And I think a lot of what the community sector can offer is that space to come alongside someone, understanding the reasons behind that, really be with them as a human and help them get through that and help address some of those barriers that people see, because often, well, as I said before, there's a reason for that. It is often because of some past experience that someone's had. So then being able to be alongside them, to empower them to do that, I think is really important. It's something that organisations like ours can really offer.
Yeah, definitely. Okay, there's some lady in the back. Yeah, so this will be our last question, and I think Daniel's just going to come and summarise our day closing remarks. So go for it.
Afternoon, everyone. My name is Cohen from Western Salford. I'm actually asked a question with in line with what she asked. My question specifically is, how do you tackle loss to follow patients from the first point of contact?
Who would like to answer that one? Let's go for one person who wants to do that.
Sorry, I didn't quite hear the question.
We didn't have to. I'll tackle loss to follow patients.
Lost the follow-up.
When after the first point of contact, when you lose the patient, what do you do after that? Culture forward.
Thank you for your question. So I think the first thing we need to do is a data. When people come to us, we cannot just store their data so much. So we had consent forms, like we asked them, can we contact you? So in 2 weeks, if we contact that person and they respond because they have consented, then you've got someone to move forward. However, if they don't answer and so on, there's not a lot really you can do because we are governed by the laws of data. You can't keep the information beyond what it's intended for. So I think that's what's happening. But seeing that most of the people we're dealing with, being trusted, you find that they're coming from maybe a church group and so on, where, we're with them together. So we're able to go to that place. Because even though they've consented today, if they don't answer your call, you can't meet them on the street and say, by the way, how's your blood pressure? It's against our practice. You cannot do that. So, yeah, that's what I can say.
That's a really nice segue to, I think, building that relationship with primary carers. And just to finish off, the final comment from me, I think we've talked a lot about trust today, and especially this afternoon, from people around services, clinical services. I wonder if there's a lack of trust from primary care to voluntary organisations that are really professional in their setup. And that makes me think about the next evolution of the work that we're doing and how we make that better. And just want to say a final thank you to the panelists, and then I'll hand over to Daniel for final remarks.